Good morning, good afternoon, good day, everyone. Pleased to have our second seminar series as part of this Alumni Network seminar series. Very, very happy to have a dear colleague of mine, Dr. Hope Mackline, here to present about public and patient involvement and engagement on antimicrobial resistance. Mackline is a medical doctor from Uganda, but now working as a project manager for the Centers for Antimicrobial Optimization Network in Uganda. And at her site there, she and her team are leading the way in both community and policy engagement on better use of antimicrobials. So pleased to have you this morning. Gonna hand over to you, Mackline. Thanks so much.
Thank you, Kerry, for the kind introduction, and I think you've said it all. Happy to be here and be given a chance to share our work that we've done at IDI in public and patient engagement on antimicrobial resistance. It's been a lot of work, but I've tried to summarize it in a few slides, and kindly feel free to pose questions at the end, and I'll be happy to respond to them and share more experience as we move on. We'll try to summarize my work in about the 45 minutes that we have, and feel free, please to note down whatever you feel that you want to ask, and then we'll deep dive into this at the end. There will be also some links and QR code to scan for more, for you to view more of the work that we have. What is here is just a summary of part of our work. But otherwise, I'm happy to meet the Fleming Fund Fellows who are the alumni. And I hope wherever you are doing similar work that we are doing here in Uganda. And this work or this presentation will be probably a light or a hint on what probably you could pick from what we are doing and probably employ it where you are, or you could have probably done some much more work that we've done in here. I would be probably along the way try to pose a few questions if allowed, and then we see how to make it meaningful and engaging. So at the start of CAMO-Net, which is Centers for Antimicrobial Optimization Network here at the IDI, one of the things that CAMO-Net aims at is not just doing research, but doing research that is contextually fit for the environment that you are working in, but also making sure that whatever you do is meaningful and helpful to the community and the environment that you're working in. So there was a part that you need to focus a bit more beyond research, which we brought in as public and patient involvement and engagement to make sure that the research that you do becomes meaningful and impactful to the communities for which we serve or for which we do the research in. Otherwise, when you do research and you keep it in your computers or write it in the peer-reviewed journals, at the end of it all, the person who is supposed to benefit from it at the last person or the last mile does not understand what it is, especially in our area of AMR that is not very widely known as how HIV, TB, and other infections are being promoted. So I'll move to my next slide, sorry, and let me know, please, if you're able to view my slides. Kerry, I would want to confirm from you.
Yes, okay. I can see them, thank you.
I'll proceed then. So I don't know if each of us here on this platform that I'm presenting to, all of us have heard about what patient and public involvement and engagement is. But a little bit of it is what it talks about, or what it means is that you designed to build trust among the public and stakeholders, where you create opportunities for people to be informed, contribute, and collaborate to the work effectively, work that you've been doing widely in the community. Why? When you're starting research or you're doing some bit of capacity building, you would want to know what the needs of the people and their experiences are before even you start doing the work. Identify what their services they need. They share with you their ideas. Get involved in the design at the start of the program. And then you plan with them. You get from them why the services are needed and what change there need to be made. And probably you want to get their priorities in whatever you're doing. And these members of the community, or the stakeholders you are engaging, you would want to know what you're doing. Is it important to them? And involve them in making decisions about their treatment or the intervention that you're going to provide. So look, there have been times when you do a research or you do an intervention and you find that the intervention you're providing for the people is not what they need. So you come in and probably assess and say, for example, in our low middle income countries, you want to think that probably the community is lacking water, and you come in with your idea that you want, for example, to put for them pumped water, build on taps and give them. Whereas that's what you think is their need. They may not be having vessels for fetching water. You put in water, you're thinking they are not using this water, but you're missing out their major need. So when you engage them, engage the public, you get to know what the experiences have been. Why are they not fetching this water or not getting the water that they need? Probably it's not the water that they need, but what to use to fetch this water. So that's one example. It could be treatment, it could be something else. So when you engage them at the start, get to know that whatever you pick or produce out of your research is what they need. And this ranges from the community. When I talk of patient public engagement, I'm not meaning only the patient or the households, but it stretches to the stakeholders who are in policy, for which at the end of it all, you want to know if you're contributing to their decisions of whatever they are making to make an impact in the community, whatever you're doing. So these are some of the examples why you would want to engage the community and why PPIE is very important. I will move to the next slide. So there are quite a number of levels that you would have while you're engaging the public at the start of your program or as you conduct your research. So one, you would want to first inform and then consult, involve them, and then at the end of it all, collaborate. For the informing part of it, this level seeks to provide the public with the balanced and objective information to assist them understand the problem that you're trying or looking at. Secondly, when you consult, as I have said, then you want to know, is this what they want? You get feedback from them. Sometimes you do co-creation of what they think they want, what you're bringing. Is it an intervention that they need? Is it going to be influential? Is it going to have an impactful, and if you bring this intervention, is it going to be impactful on their lives or on their way they are living, or are they going to benefit from it? Otherwise, you may implement something that is not going to be needed or make an impact at the end of it all. Then when you involve them in designing, in making sure that they are part of what you're doing, then they feel that what you're bringing in is what they need and they feel involved. And whenever you involve the community, consult, for example, the local council people, religious people, and the patients themselves and the policymakers, then they become part of your program and it is easy to disseminate and also pick the information as you require. Collaborating, I'll take an example of CAMO-Net Uganda program. When we started, we thought about who we needed. And in the next slide, you'll be able to see that clearly. Who are our collaborators? Who are our stakeholders that we need? We have civil society organizations that already are in this work of infection control, doing work on AMR. We have organizations that have also been in the AMR, program. We have the policymakers. So we made a framework for which I'm going to share with you in the next slide. And this is an IDI framework. We did not copy it anywhere. We just sat back and said, if we are starting CAMO-Net work, we want to do patient engagement and stakeholder engagement, what do we need to do? So we had a quadro kind of plan and said, let's draw our map and see who do we need. So we thought policymakers are very important, the academia and the community. This just to say that they are not the only ones, but we were just focused at the start and we said, let's see who we need at the start. Policymakers. These policymakers are the ones that make decisions and forward, what needs to be done at that level and pass guidelines, pass laws that probably impact on the work that we do. So what did we do at that level? We thought, could we part of the groups that are forming the Parliamentary Forum on AMR? This was not there. It wasn't existent by the time we started CAMO-Net. And we did some work, presented to them our results together with the other individuals that were doing AMR work. We managed to establish a parliamentary forum on AMR, and down in the presentation, you'll be seeing what the outcome of this has been. This was also a platform for disseminating our study findings and policy recommendations. So it was an idea that if we do work and we don't involve policymakers, then it will be seated in our laptops and in our journals and nothing will be done. And then we were strategic enough to know that they are decision makers who would help us integrate our AMR requirements into the national strategies. So when we come to the ministries, and this year I'll talk about the Ministry of Health in particular for Uganda, we know that here, these are individuals that advocate for more financing in AMR research. We also a platform for dissemination of our work, but also support Ministry of Health implement the Uganda National Action Plan objectives. And I believe wherever I'm presenting to, most of your countries have these national action plans on antimicrobial resistance. So the best way to fit our work and CAMO-Net research and capacity was to penetrate the ministry and engage them so that we get that platform. But also we don't do work that is outside the National Action Plan of Uganda on AMR, rather we contribute to whatever the objectives have been. And we did this a lot. And actually I'm happy to mention that one of our objectives was, one of the objectives of the National Action Plan of Uganda is to patient engagement, learning, and community. So which is one of the parts that we've really contributed to widely, plus the research bit of it. So this is what our focus was on that part 2 strategy. We went and looked and said, we need the communities. These are the people that benefit the milestone, the last mile of the work that we do. Who does it benefit? It is the community. If the communities or the people within the community don't know what AMR work that we are doing, even Wellcome Trust will be giving us money for nothing. We will write, we will do research studies, but if we don't involve the last person in the community, then we won't be able to be impactful in the work that we are doing. So how did we approach this? Uganda has community healthcare workers who reach the households, and we call them village health team members. So we brought these ones on board and we formed cohorts. We've trained so far more than 50 VHTs, and that was cohort 1. So far we've done 2 more cohorts, aiming at equipping them with knowledge on AMR, but also knowing that they are the ones that reach at the household level, and they would be very important in response to AMR. If the last person knows AMR at the household, then they will be able to know how to prevent it, how not to misuse drugs, how not to do self-medication and other things that contribute to development of AMR. So we would also organize community AMR awareness events. An example is that we've done AMR runs, we've done music and dance and drama to engage community members. We found that using dance and drama, music, dance and drama is very important. What are the things that people contextually and in our culture really a treasure. It may not work for the other countries like the UK, where they might have a different, a mode of engaging the communities. But here, contextually, as I said, for the African communities, I think we engage more into music, dance, and drama, and information transferred or made in using these dance and music and drama reaches the people very easily and quickly because we relate to it. So we at IDI have a music, dance, and drama group that we've actually engaged to create some content on AMR that we've used during our community engagements, even both for the policy stakeholder to engage and teach the communities, but also create information to improve the knowledge and equip the community. We've also had various engagements on AMR for the healthcare workers at the different healthcare centers. In Uganda, we have a structure that, you have hospitals, you have healthcare centers, and those are the lowest that we have. So we've engaged some health centers, engaged the leaders, and also the patients, as you'll be seeing down. For academia, this has been mainly in terms of research. The research outputs that we've done at that level have been accessible to the research community, to the academia, and others. We've also supported the establishment of student bodies, especially at the universities, creation of antimicrobial clubs. Because of the work that we've been doing, we've actually been also called on to do that, to help out with the establishment of those clubs at the universities, but also we've engaged the primary school students. So when you teach a child about what AMR is at that level, they can easily learn and also translate it to their parents and at home. And in particular, we learned all about, hygiene in school. That's why you would know that you need to wash your hands before you eat. So we thought if you engage the students at that level, primary level, then it is important that they learn it and they carry it on. And we also are aimed at creating those small clubs in those primary schools so that we follow on and get a patron. Then the Minister of Health in those schools become, the leaders, and then engage other students to continue the work that we have established. Over and over, we go and check on them once in a while to see how the work they are doing is doing, or if the club is still running. We've also done some bit of development of some training materials, visual, which we also distribute probably in schools and also in the hospitals. So this is a little or a few of the things that we have done, and that's what we planned as our strategy. Some of them have been achieved, some we are still continuing to work on them as we move on with the research work that we are doing at the IDI. So the next slides really speak to the framework, what we've done. For example, what I've said is that here we were in the community market trying to raise awareness for AMR. And as I said, through this, communities have been trained. People have been given a chance to ask and request, for more information, come to back and, teach us. But these are some of the sites and works that we've done. When I talk about the academia and the Ministry of Health, for example, we've engaged the ministry to a level of having the Director General of the Health Services at the ministry attend some of our workshops. And through this, we are sure that we are talking to the right person who will go and talk to his teams, for example, those that are involved in antimicrobial stewardship at the ministry level, and say, look, this is what work has been done at the IDI, and these are the results. So how can we support, for example, the hospitals where they have found that they are not doing culture and sensitivity to make decisions on prescribing antibiotics? Then, for example, the commissioners would move and also use the same information to move ahead, and as they make their trips and make their support supervision, try to emphasize on the work that we've shared with the ministry. And these we created, I think, about 2 or 3 meetings where we invited the Ministry of Health in, members policymakers, and we would now and again do kind of a presentation, but we also pick from them what they think would be done. And for the bit of the Ministry of Health and Academia, we continued to explore the opportunities for collaboration, but also, as I had said, it was important that from our engagements with them, they asked that we could do student AMR clubs, which we've started on, but also encourage them also to do research on AMR. And then one of the things that we are still doing and struggling to do as well is to make sure that we have the information, education and community materials translated into our local language. You find that most of the information that is available is in English, and if you want to impact the person at the lowest level, an individual in the community, then you should speak to them in the language they understand. And this was actually forwarded to one of the groups under the AMR, committee at the ministry, and work is being done to see that we have materials that can speak to individuals. And then also have standardized AMR training packages for various categories of stakeholders. We realize that, we have general information, and most of this information is coming from probably the World Health Organization and higher levels, but we don't have specific categories or packages for different stakeholders. For example, the policymakers, most of the material that is there speaks to the healthcare workers, but for these other groups like students, community members, the information is at large and it's unspecific. So that was also one thing that we wanted to push forward, and also still advance collaborations for research at that level, both from the ministry and academia and others. So this shows one of the workshops that we had with the policy makers, and the gentleman that is standing at the podium is Dr. Charles Ayume. This is the chairperson for the Parliamentary Forum on Antimicrobial Resistance, and he has actually helped us push most of these requirements that we need, or what we've put forward. And he has showed commitment to moving forward the agenda of AMR at that level. So here he was attending one of our workshops, and he was at the forefront of actually forming the Parliamentary Forum and being the first chair for it. And we had roundtable discussions of what we need, what Uganda requires in terms of surveillance, in terms of lab, in terms of social aspects of AMR, what we need. And then that's what, when what I discussed up also came up, how do we collaborate with the policymakers to make sure that what we need is moved forward? And then way forward is that we wanted to advance policy and resource mobilization. So one thing that we've really achieved, which I'm going to show down, I'll speak about it, we have achieved a lot with the AMR forum, with engaging the policy, and I will probably show you down some of our achievements that we've made. But also we agreed that we host regular AMR roundtable discussions to align with the national priorities, share insights, and also inform actionable policy directions. Why? If you don't bring the policymakers near you, they would probably, they have a lot of national issues to discuss. So they will forget what you, who is doing AMR, and you want your also request to go through, they will forget. So we thought we would engage them more often and have more roundtables. As we produce more research, we engage them, disseminate, tell them the results and what the policy recommendations are, and then probably they would take it up and move it forward. But also what we realized is that most of the people who were on the health committee didn't know that actually AMR was an issue or was a problem. So when we presented to them in the parliament, they said, look, oh, this is something that is going to be a time bomb, and they took it up. So it's important as you do your work wherever you are to make sure that the policymakers are part of your work. So this is one of the engagements that we've had at one of the health centers that we work with here in Uganda. And we also realized that patients have a lot of questions. I would want also to acknowledge that AMR is not only a community or a patient problem, but it goes beyond biology. It goes beyond the population. It goes beyond policy. It's something that everyone needs to get to know, and then you get combined effort and combined information. And truthfully, it's not something that you're going to mention today. Someone picks it up, but it's routinely needs to be integrated. For example, in health centers, you need to have champions to speak to these patients every time they come in, and then you build that connection. So it's not something that you're going to go there and do in one day and then go away, but it's a continuous, engagement of patients, healthcare workers, and others that are involved in the fight of AMR. Now, I would want you, if you have time, to scan this code. It will take you directly to the pictorial, but also there is a video that we've created that you would follow up and see the most of the work that we are doing. If we have time, the chair, Kerry, at the end of this meeting, I would be happy to play that video. But if we don't have that time, then kindly members scan that code, and you will be able to access some of the work that we've done, and you take time to read it. I'll just give it a second so that people are able to scan, but I'll also bring it back at the end of the presentation, whoever has not scanned. Okay, so on this slide, I have really summarized what we have achieved. And this speaks to the importance or the benefits of involving the public, the patients, and other stakeholders like the policymakers. So at the level of policy, ministries, departments, and agencies, we have been able in the last 3 years that we've worked to be part of the people that have strengthened advocacy and coordination through participation in establishing an operational parliamentary forum for AMR. So that was a tick because it never existed. And through your engagements also where you are, if you don't have such, you can see and plan on how to establish it, because it is the channel that it could be through another, a policy department, but as we found it easy to have this and focus on an area where we thought we would have a channel through which we can, move our agenda through, and it was the parliamentary forum. We also have seen or contributed to an increased influence on the national health priorities through a contribution to the policy statement that was made, I think, last year at the Ministerial Health for a discussion. And what did this include? Funding, a focus on major areas, for example, surveillance, laboratory, and others, which is still at the ministerial table, but we shall be following it up maybe in phase 2 of CAMO-Net to see how it moves forward, and probably we get some funding in particular for that. And it has been mentioned actually many times at the ministry. We have also enabled legislative impact through engagement in processes which have led to the passing of the NDA Bill 2025 in March 2026. So what does this bill talk about? It's actually a wide bill, but I think as the parliamentary forum that we contributed to a formation and our engagements with the National Drug Authority contributed some part of the decision of that bill, which is, I think, clause 5. And it is a bill that introduces significant reforms to the regulation and strengthen the legal framework for combating antimicrobial resistance, AMR. And the parliamentary forum heavily influenced this bill. So indirectly, through our creation and informing, making noise about AMR, this has been possible. And it was recently passed in March 2026. It's a long bill, but we are happy that we probably could have contributed some part of this bill. Why? Because we engaged the stakeholders early who are relevant, and we showed the importance, of the work that we're doing. But we also have been able to influence practice through establishment of antimicrobial stewardship committees across the 9 regional referral hospitals. Yes, they were there, but we strengthened. Every time we'd go there to collect data, implement, but also disseminate. we were able to make sure that these committees are active and they are currently working. On the part of academia, we've increased the interest in the AMR research through the dissemination at different institutional and national health conferences, growing student body who are engaged in AMR through participation, conferences, launching university clubs, and also strengthened academia policy and academia practice linkages through promoting translation of research into action. We've also introduced AMR, as I said, to primary schools, which I thought was very important to have young people grow up when they know that we have a problem of AMR. At community level, we've had health extension workers who we call village health teams, trained with an aim and thinking that since they reach the last household or the individuals, this knowledge will be translated and transmitted to individuals who need it. And we've also enhanced public understanding of AMR by translating some research findings into local languages for a wider acceptability and visibility. We've also increased community engagement using culturally relevant approaches, as I said, such as drama, dance, and to communicate AMR messages. Of course, on this last bit, what we aim to do in CAMO-Net 2, or if we are able to get funding, and also through our extension that we have, we would want to be very kind of practical and see if we can get the impact through a qualitative research. And now we move from, saying we have impacted on 5,500 people, but what exactly can we put to paper to say that this is the impact that has been created? So we hope to conduct, research, qualitative research, have some interviews with individuals. We've had interviews with some people who have been directly impacted by AMR. We have a few number, those ones that have been impacted. We have some videos, we have some, testimonies or how it has impacted on them, but we want to go ahead and get a qualitative aspect out of the work that we are doing so we are able to present it better, probably for more, either funding, but also to show the extent on paper that AMR has impacted on people. Yes, so that was my last slide. And I would want to say that as the Uganda Hub, we have been really very loud, creative, and relentless through the work that we've done. And we hope to do more and more. And happy to share our stories more if called on. And we are also happy to hear from what other countries or what other communities are doing in terms of using, PPIE to combat AMR, but also to disseminate the knowledge on AMR and what they have gained and through this work of PPIE. Thank you, everyone, for listening to me, and thank you, Kerry and Mike, for giving me the opportunity. I will scroll directly to the QR code. I don't know how many minutes we have, Kerry, that I've used, and if there is time to have the look at the questions and answer, and also look at the video. Over to you, Kerry.
Absolutely. No, thank you so much for that great presentation and such an important part, as you said, of the research about, engaging communities early and ensuring that you're actually achieving relevance and the impact that affects the local communities, but also engaging in ways which are culturally appropriate and reaching people not only in their own languages, but also by their own interests in drama and song and dance and having runs. I love the idea of having, fun runs for AMR because you see them for other diseases and things all the time. So it's incredible that you guys have done that in Uganda. And also, again, as you've already said, engaging with policymakers and how that needs to be linked with national priorities. Really, really incredible. I don't see any questions in the chat just yet. Feel free, please, anybody to put questions in the chat. I did want to ask, actually, you guys have done so much and engaged across so many different forums, and you, I think, I know Dr. Charles Ayume, he's been recently in the UK, and, obviously he was at our CAMO-Net conference as well. it's really incredible the links that IDI have with policymakers already. I wonder, just for your advice for groups or individuals just getting started, is it about knowing the right people to get sort of in the door? How do you start that? I'll go to Darius.
Oh, yes, Kerry. And as I said when I started, it's just drawing and knowing the right people, as we said. Who do you engage? But also we had a better, I don't know, I would call it an advantage that IDI was already doing the Fleming fund work and had laid for us a ground. So they had done a lot of work with the ministry. It's actually the policy bit of it that we brought on board, but we already had a platform on which we entered from, even for the hospitals, even for the health community work that they had done. So it's, yes, Kerry, it's knowing the right people and prioritizing whoever you are engaging with, and then you get your work smoothly done.
Amazing. Thank you. I think Darius has a question. Please, Darius. Not sure, Mike, if you're able to unmute and ask your question.
Okay, thank you. I was unable to put the questions in the chat. It was disabled for some reason. But thank you, Mackline, for the presentation and for the work done with engaging the community members in raising awareness about AMR. My question was, I wanted to know what the community's understanding of AMR was when you interacted with the different community members. I mean, the people like in the markets. Did they know what AMR was and what were their most pressing needs relating to AMR? I don't know if you were able to capture some information on that. And the second question is, how would we be able to combat certain cultural or farming practices that tend to propagate a lot of AMR? Because here in our setting in Uganda, people use there's a lot of antimicrobial misuse, can I just say. Someone is feeling unwell, they'll walk to the pharmacy and just buy the drugs. So how can we combat such practices to have any meaningful impact on AMR? Thank you.
Thank you, Dr. Darius, and happy to see you as part of the group that is listening in. Dr. Wachi was one of the people that attended one of our workshops, and I'm happy to see him here. So the understanding of AMR by the community. Well, I want to mention that AMR is still a dilemma. Why we don't have a single word that defines AMR, and that is what we've been actually struggling with. But a few pockets of people can let you know that, AMR, I'm just going to report verbally. They know that when you take something, they've taken some medicines at one point and they have not worked. So when they go to hospital, they tell you, this is not working. We need to change for you something, new. But they don't have that idea, a technical idea to know that the drug is not working. But some of them had faced that challenge of saying, you're in hospital, they go and give you the medicine, you go back home, you take it, and then you don't get better. So they had a rough idea of, someone has been taking drugs, they don't work, or sometimes someone has kept drugs, they have taken them over again, and they're not working. So Darius, we still have a lot to teach the communities. The idea of AMR is still very, very, very vague in our communities. And one of the things we are talking about, and I would want to thank the CAMO-Net South Africa, I think they are trying to get a word or how better to communicate AMR to our communities. Really, I want to tell you that the AMR is very vague. Even by the time you try to tell someone that AMR is this, you've used 1,000 words to make sure that they know what AMR is. Whereas when you say HIV/AIDS, we have one word in Uganda. And someone is right away knowing that this is, HIV or this is TB. So that is the thing that as people in the area of AMR, we get to see at that level at the ministry. That's why I'm saying there is that part of the NAP that is talking about training, education. How do we get this information disseminated, but also not confuse people with many words for AMR? The understanding was very, very vague, Darius. Secondly, I think we focused mainly on the human, AMR, and forgot the other two areas of One Health, which is the environment and animals. I want to agree with you that there is a lot of misuse of these antibiotics, both for farming practices and others. So what meaningful way or meaningful we can, it's really through what we've started on of educating, but also this thing has an issue of economic impact, because I know we have rules and guidance that, when you use antibiotics wrongly, or if you give, for example, your animal an antibiotic, there is a period that you should not probably eat or slaughter that animal. But because there are economic, aspects associated with it, it becomes hard to tell a farmer, don't get the milk and, sell it after when they are getting money out of that. But to me, truthfully, is we will need to start from talking, but also policy and implementation of what we put on paper by the government to take part. But there is still a lot others that we can't do now, but we can start on it. We do that, the knowledge, dissemination on what the impact is, but also I think we need a strong policy guidelines implementation at that level of the ministry. Otherwise, we can speak and speak and speak. If there is no implementation and guidance at that level, we may not do much. But I think the knowledge is there. The knowledge in some individuals may not be there, but most likely it is what they are getting from the products that they are selling and the money issues that bring out that aspect. But we need a combined effort from the policy, the people knowing that misuse of antibiotics is bad at that level, the farmers and others, but also if the people are not economically stable and you're telling them not to slaughter or sell the milk that they have gotten after using the antibiotics, is going to be still hard. So, but the only thing we can do is that we can start. And when information is outward there, then we can also look at other things that can come in to supplement that.
Thank you so much. I think so true. And yeah, tell them how to, the economic argument for combating AMR is so huge, and I think needs to be highlighted massively, and people would actually do something about it. We're at time today, but thank you so much. This is an amazing presentation, and anybody who hasn't yet, I highly encourage you to watch the videos that the CAMO-Net Uganda team has produced. Their drama and dance they're just really incredible, energetic, amazing videos. So very highly recommend to watch. Thank you again so much, Mackline, and thank you to you all joining today. Thank you for joining our second seminar of our Alumni Network series, and look forward to seeing you next time. Everybody have a lovely rest of your week. Thanks very much.
Thank you. Bye.
Bye.